Your patient cut their carbs by 20 grams a day, but their bolus insulin requirement fell by 30%. These two numbers do not match, and understanding why matters clinically. When you look closely at the insulin dose data from the GLP-1 trials in type 1 diabetes, something doesn't add up in a way that is important to understand. In the Adjust T1D, carbohydrate intake dropped by about 20 grams per day in the first 4 weeks, but bolus insulin requirement fell by 23%. Disproportionately more than a 20-gram carb reduction would explain. In Turtle 1, the tirzepatide trial, bolus insulin requirement dropped by 49% by week 2. That is not a diet effect. So what is happening? A few mechanisms working together. GLP-1 receptor agonists slow gastric emptying, smooth glucose entry after meals, and reduce prandial insulin demand. There is also evidence in type 2 diabetes that semaglutide improves insulin sensitivity. And while this has not been directly measured in type 1 diabetes data, the data strongly suggests that something similar is occurring. In the Adjust T1D, post-hoc analysis also found that user-initiated meal boluses drop from 4.6 to 3.4 times per day. A reduction in bolus frequency, not just size. And the automated correction boluses from the AID system were not significantly affected. The system was not compensating for missed boluses, so the bolus need generally decreased. The basal to total daily dose ratio shifted from 0.56 at baseline to 0.62 at week 26. The entire insulin profile changed at just the starting dose of 0.25 milligrams. The clinical implication, bolus settings, meaning your insulin to carb ratio and your correction factor, they need to be adjusted for first and most aggressively. AID systems operate within the parameters you set. If those parameters do not change, hypoglycemia risk is real, even on a closed-loop system.